Yeah, hi guys. Very good morning, one and all. Hope I'm audible and visible to you. Yeah, hi guys. Very good morning, one and all. Hope I'm audible and visible to you. Yeah, hi guys. Very good morning, one and all. Hope I'm audible and visible to you. I want you to come to live. Okay, so come to streaming live. Shall we start or wait for some time? Yeah, we'll wait for 2 minutes. I want you to come to live streaming so that there will be no lag. Okay. Yeah, I think like 100 order there. Yeah. So today in this session is basically for pro life students 2026 batch. Okay, and most of you are requesting for a demo. So I thought of going for a live streaming on YouTube, like so that I can post the students this class as a demo. And I hope most of you know me. This is Dr. Srikanth from Team MDS Conquer. Okay, I have a 10 years experience in teaching the NEET MDS students of all the subjects. So my class may be general surgery, but it will be an integrated class. Means the mode of teaching of MDS Conquer is always integrated. Like we will be teaching the main subject general surgery, but here and there, if the concepts are integrated or if the numbers numericals are integrated, or if anything is integrated, similar things are fine. You get across in a different subject. Okay, I'll try to integrate here. Okay, so this is called as a comparative reading. Okay, I strongly believe whenever we are preparing for entrance exams, particularly NEET MDS or INICET, or let it be, or preparing for PSC exams, dental government PSC exams are nowadays trending in the market. Yesterday we got a notification of Bihar of 808 posts of PSC, and 10 days back we have a notification of MPSC with 380 odd. A month back we have a notification of Kerala PSC, and all these, like PSCs are nowadays very trendy for a dental student. So keeping that in mind, or any sort of international dental license exams also, MDS Conquer is going to help you in the integrated pattern. So whenever you're preparing entrance exams with huge contents, 20-25 subjects, lots of things to be done, it is always, from a student point of view, I strongly recommend it is always an integrated mode that makes your preparation easy and simple and focused. Easy, okay? Other than you're reading two subjects together, same concepts in two subjects together, or integrated together. That's what we do in our third BDS, okay? So first BDS we have physiology, second BDS we have general path, pharma, micro and everything, and third BDS we have general medicine. General medicine is nothing but an integrated part of your physio, pharma, path and everything get integrated. That comes in your general medicine. How it is integrated there. Here we'll try to integrate each and every subject with other subject, a medical subject with a dental subject, a basic subject with a clinical subject, to make your preparation easy, simple and comfortable. Okay, right? So that is a basic introduction about that. Shall we start without wasting any time? I want you guys to come to live stream so that we'll start with the proceedings of the class. Okay, so this is a pro live session. Okay, so this is a pro live session. So MDS Conquer provide somewhere around like 100 to 120 pro live sessions throughout the year. The pro live sessions are basically interactive integrated mode of teaching. Okay, where we'll be discussing the previous year questions, or the questions which are given the latest both for dental as well as medical, and we'll try to teach here. Apart from the smart video content, whatever we have a 1400 to 1500 repository smart videos covering all the subjects and all the topics which are important from the examination point of view. Apart from this, weekly we'll be having 2 pro live sessions to the pro live students exclusively. This is the live session. Okay, and of course the live sessions preferably will be on evenings. Okay, it will be from 6 o'clock to 7:30 or 6 o'clock to 8 o'clock. Okay, and most probably on Sundays we can keep some live sessions, because keeping in mind of interns or keeping in mind of clinicians will be busy. And even if a particular student is missing a live session, okay, immediately the next day the recorded version of the live will be available in your account for an unlimited access. Okay, make a note. Conquer provide all the videos of an unlimited access. We don't have a limited access. Okay, so you can watch video n number of times. You can watch video from any time, and the video will be there in your account, whether it's a live class video recorded or whether it is a already recorded videos. Everything will be available in your account throughout your preparation phase without any time limit. Okay, I hope this is very, very clear. Yeah, we have 130-40 students. Guys, I need a very, very quick response. First and foremost thing is I want you to come live buffering. Okay, means I want you to click on the cursor. Okay, the timeline cursor, straight away drag to the one end. Okay, so that you'll be coming live. So there will be no time lag difference. If I'm asking any question, if I am talking anything, so there will be no lag. Okay, right? So that is the main important thing to be done, so that you can be live and you can answer me, you can interact with me. Okay, clear? I want your response quick and fast. Yeah, many students. Okay, very good. So we'll start like general surgery. I'll be going a little bit slow. Okay, right? So because 2026, okay, general surgery they have recently started. So my speed will be slowly. I'm going to discuss each and every concept. Okay, right? I hope 2026 batch students are there, right? Students are there. Yeah. Gopi Krishna is there. I'm familiar with a few of the 2026 batch. Anmol is there. Yes, right. Okay, very nice. Right, 140 plus. Okay, chalo, let's start. The first and foremost concept which I'll be talking is portal pressure. Okay, so portal pressure exerted in the portal system, which is present in the liver. So that is called as portal pressure. So the portal pressure, the normal portal pressure is 5 to 10 millimeters of Hg. If they're asking in the units of Hg, or if they're asking in the units of saline, or sometimes they can mention it as water. In the units of water or saline, it is 10 to 15 centimeters of saline or water. So this is a normal portal pressure. Okay, so there is something called as portal hypertension. Similarly, how the body is going to have hypertension, there is something called as portal hypertension. Whenever this value is more than 10 millimeters of Hg, then that is called as portal hypertension. During portal hypertension, you have varices formation, whereas you can have bleeding from the varices. Okay, so varices formation can be seen whenever you hit more than 10, and the bleeding from it can occur whenever you hit more than 12 millimeters of Hg. I hope this is very, very simple concept. Okay, right? So what is a normal portal pressure? The normal portal pressure is 5 to 10 millimeters of Hg or 10 to 15 centimeters of saline. Please do make a note which units they are asking. According to that, you can go for the answer. I hope this is very, very clear. The next one I want to jump into, similar concept you have in your endo. Okay, that is called as pulpal pressure. You know that the pulp is being surrounded by dentin and which is capped by enamel. So it don't have an exit. So that is the reason why it is having a blood supply, and the blood supply is going to exit some pressure. That is called as pulpal pressure. So normal value of pulpal pressure is 5 to 10 millimeters of Hg. Again, here they can ask you, previously the question was repeated, they have asked in relation to saline or water. It is same again, 10 to 15 centimeters of saline or water. And I hope we are very, very clear, right? So pulpal pressure, normal value 5 to 10 millimeters of Hg or 10 to 15 centimeters of saline or water. The other frequently asked questions are, you know that the pulpitis has been categorized into reversible pulpitis, irreversible pulpitis. Okay, reversible pulpitis is something which can be reversed back once the stimulus is removed within few seconds. Let it be they're going to give a 5 seconds. Sometimes they can give a case description question in a similar way that the pain does not subsides immediately, but pain has subsides over a period of 15 to 20 seconds with a lingering pain or something. Then your diagnosis is going to be irreversible pulpitis, that is 34.5 millimeters of Hg. So these two values in endo are very frequently asked question. In the last 5 years of Neet and Inicet, it is repeated more than twice. Okay, so reversible pulpitis, it is 13.5 millimeters of Hg, whereas irreversible pulpitis, it is 34.5 millimeters of Hg. Okay, so I try to link your portal pressure to that of the pulpal pressure because the normal values are same for both. Okay, it will be coming in two different subjects, but the values are same for both. So if you read together, remember together, then the revision and the memory based strengthen can be improved from your side. Okay, right? I hope you are very, very clear. So those are the first two questions which I have given in the worksheet. Okay, so normal portal pressure. What is the normal portal pressure? Normal portal pressure is 5 to 10 millimeters of Hg. Here it is given as Hg. Or if it is given in centimeters of saline, then your answer is 10 to 15 centimeters of saline, or sometimes they can mention it as water. Okay, the first question, the answer is C. The next question is again the same. Normal pulpal pressure I have given. The normal pulpal pressure is 5 to 10 millimeters of Hg. Okay, the first two are done. Okay, so then jumping into a rule of 10. Okay, so as we go, as we discuss something called as rule of 10, I always discuss rule of 10 from two aspects. Okay, you have two major rule of 10s. There are many rules of 10s in the medical and dental field, but the major two rules of 10s where your questions will be moving around is, one is Millard's rule of 10, which will be coming in your oral surgery, and the next one is rule of 10 related to Pheochromocytoma, which is related to your endocrinology. Okay, so this one is rule of 10, which is also called as Millard's rule of 10, which is useful for the surgeries of cleft lip. Okay, so all 10s, right? So it is rule of 10 is basically the repair should be done approximately 10 weeks and the weight of the child should be 10 pounds. Okay, and the hemoglobin percent should be at least 10 grams and the WBC count should be at least less than, okay, it should be less than 10K. Okay, right? I hope you're very, very clear. This is a very, very frequently asked 2 marks question at a BDS level in third year as well as in the final year. Okay, I hope you guys are very, very clear. So this is called as rule of 10 related to the surgery of cleft. Then the next rule of 10 I was talking about is the rule of 10 associated with pheochromocytoma, that most of you are again familiar with this. Okay, so 10% of this tumor is malignant, can be converted into malignancy. 10% of this tumor can be bilateral. 10% of this tumor can be extrarenal. 10% can be calcified. 10% are most commonly seen in the children. 10% are familial. 10% are associated with Men's syndrome, and 10% are presented with a stroke. Right. The concern here is most of us are very familiar about value 10%. Sometimes they can ask you, not sometimes, it's already given. Okay. Sometimes they can ask you how much percentage of pheochromocytoma are benign. Okay. Malignant is 10%. The other part is 90% is benign. So you should be very, very clear. Don't blindly remember 10 and go. Sometimes they can ask you how much percentage are unilateral pheochromocytoma, how much percentage are unilateral. They can give the first option as 10%. So don't go with blindly rule of 10. Learn what is basically rule of 10, because unilateral are 90%. Right, clear. I hope you guys are very, very clear with this, right? Okay, so Cello, we'll check out the question which is given here. Of course, we have a separate pre-recorded video in your smart video folders on this particular abnormality, top to bottom discussed, very important. In the last 3 or 4 years, every year the question is coming from this particular tumor. Okay, the patient presented with a headache. Headache is a very common sign of this particular abnormality, and you have a repeated episodes of elevated blood pressure. That is the reason why I was talking about stroke, tachycardia, and the urinary levels shows increasing the level of VMA. VMA is very frequent as increasing in the VMA is very commonly associated with pheochromocytoma. Okay, and the CT scan reveals that there is a tumor in the right lumbar region, and which of the following structure is true regarding this particular condition. Okay, right. If we check out the options, it is most commonly seen as a bilateral condition. No, 10% is only bilateral. It is most commonly seen as a unilateral condition. Nice, very nice. Okay. Next, it is most commonly malignant. Only 10% are malignant. So it is most commonly benign tumor. Most commonly seen in children. Only 10% are seen in children. So it is most commonly seen in the adult. Okay, so they're asking, the keyword in the question is they're asking the true statement, and the keyword in the question, according to me, the best keyword in the question is VMA, which is very, very specific to pheochromocytoma. Right, so not A, not B elimination, not C. It is commonly associated with Men's 2A syndrome. We'll be discussing Men's 2A syndrome further in the next slides. It's already covered for you guys in the adrenal gland smart video. 20-25 minutes adrenal gland smart video is there in your general surgery folder. You can go back and check it. All the types of Men's syndromes were clearly top to bottom discussed. Okay, right. So the answer is C. Then jumping into the next important aspect, that is your carcinomas. Thyroid carcinomas are very, very important for a dental student in the examination point of view. Recent INICET, okay, a few months back, also we have a question on this thyroid carcinoma. Okay, right, for both medical as well as dental. For medical, there were 2 questions. For dental, we have 1 question. Okay, so jumping into the contents here, like the most common type of carcinoma of thyroid is papillary carcinoma of thyroid, which has a very, very good prognosis. Very good prognosis. It is most common. And don't get more, as a dental student, whenever you talk about papillary, we may get confused with the histological types of ameloblastoma, which we are more familiar from third BDS to final BDS. Like every year, third BDS, final BDS, it's an important question. So here, the most common type of histological type of ameloblastoma, what is your answer? The most common histological type of ameloblastoma, what is your answer? Yes, right. That is follicular type. Okay. Ameloblastoma, most common is follicular type. Thyroid carcinoma, most common is papillary type. So don't get confused. And when I'm talking, I clearly mentioned papillary carcinoma to remember 2 L's. One is spreads by lymph. Metastasis occurs to the lung. Okay. So for most common metastasis organ is lung, followed by bone, followed by liver, followed by brain. The most important thing is I want you to remember L and L. I want you to remember L and L. One is lymph and second one is lung. The next comes is, it is most commonly seen in the women of 30 to 40 years of age. Okay, most commonly seen in the women of 30 to 40 years of age. And the history background, they can give either radiation to any of these head and neck areas, or the patient may have a long-term history of radiation or long-term history of thyroglossal duct cyst. We have already discussed, like, the biggest difference between the thyroglossal duct cyst and other thyroid gland abnormalities, other thyroid gland swellings, is thyroglossal duct cyst will move with the protrusion of tongue, because the remnants of thyroglossal duct cyst will be there from thyroid gland to that of the foramen cecum, which is present on the tongue. So whenever these remnants are not, whenever this duct is not removed, okay, so there will be leftover, the connection will be leftover from the thyroid gland to that of the foramen cecum, which is present on the tongue. That is the reason why whenever you protrude the tongue, there will be movement, which is a very, very specific feature of thyroglossal duct cyst. So whenever the patient gives a history of thyroglossal duct cyst and followed by she is having a thyroid carcinoma, preferably the case description should go for papillary carcinoma of thyroid. And even in recent Neet PG, okay, for the medical students, for the medical friends of us, there was a question on this concept. Okay, so there was a question, the patient has some sort of carcinoma related to that of the head and neck area, and there was a radiation therapy that is done for the patient. After 5 years, there was a carcinoma of thyroid gland. Along with that, orphan annii nucleus, they have given histology, that is different thing. But a radiation is a very, very key word for that particular question. Without histology also, you can go for the answer as papillary carcinoma of thyroid. I hope this is a very clear concept. Okay. The other important area where n number of questions are coming from for us, for a dental student point of view, is that is your orphan annii nucleus. Okay, this histological photograph of orphan annii nucleus, they are going to give you as a diagram based question for you. Okay, right? So orphan annii nucleus are seen in papillary carcinoma of thyroid. In the recent INICT, they have asked what is the gene responsible for occurrence of papillary carcinoma of thyroid. Okay, so please do make a note of it. BAFV600E gene is responsible for papillary carcinoma of thyroid, and the mode of mutation in this is point mutation. Where does this concept of point mutation is going to come? This is general pathology. This will teach in general path. That's what I'm telling. I'll try to integrate a question there, a concept there to concept here. That is the difference here. Okay. Then if you are talking about the treatment of papillary carcinoma of thyroid, we regularly go for near total or total thyroidectomy. If I told you that lymph is involved, right? So whenever the lymph nodes are involved, you have to remove the associated lymph node. That is the treatment plan of papillary carcinoma of thyroid. Papillary carcinoma of thyroid can be in combination with other carcinomas also. Okay, but whenever you see papillary, give priority to the papillary as first. Okay, so whenever you see histology that includes papillary as well as follicular, it is considered as papillary itself. Okay, right. I hope this is very, very clear, guys. Okay, so most important things is it's most common. Okay, most common, good prognosis, L and L, one for lymph and one for lung. Treatment is near total or total thyroidectomy with associated lymph node. Women's are most common, 30 to 40 years. Orphan annii nucleus, and the gene that is responsible is a recent INICT question that I want you to make a note. There is something called as occult carcinoma. These are basically carcinomas which are of less diameter. That is particularly straight away line from your B and L. So most of my written notes or written slides or written whatever it is directly from your B and L. That is the most standard textbook for your general surgery. So in this carcinoma, there is the diameter will be less than 1.5 centimeter, and this is going to have excellent prognosis with a little clinical significance. The prognosis is very, very excellent for this type of carcinoma that you have to make a note. Okay, right? So yeah. Similarly, you have something called as occult caries. What is the occult caries? Anyone? What is the occult caries? Can anyone tell me? Yes, it is basically hidden caries. Okay, it is basically hidden caries, which is going to come under the concept of your operative dentistry and pedo. Okay, it is called as a hidden caries, or it is called as fluoride bombs. Okay, so this hidden caries or fluoride bombs can be visible only on a radiograph. Only on a radiograph. Clinically, you cannot see this. Okay, because of the presence of high fluoride, there will be the surface layer will get remineralized. Okay, remineralized, but the subsurface layers, the layer below the surface, will not be remineralize. So that is the reason why the caries will progress in that direction, but surface you cannot see. Clinically, you cannot see. This is a very, very frequently asked question. Caries which cannot be seen clinically, but can be diagnosed only with the help of a radiograph. Occasional radiograph of an OPG is seen. Suddenly you see a caries lesion, but clinically it is not visible. The answer is hidden caries or occult caries. Okay, right. I hope you're very, very clear with this particular concept. Again, on other side, you have one more question, reverse to this. Okay, caries, a type of caries which can be seen clinically, but cannot be seen radiographically. A caries which can be seen clinically but cannot be seen on radiographically, because for a caries to be detected on a radiograph, what is going to happen? It requires some demineralization. A basic demineralization cannot be seen. For example, you see white spot lesion, or you see initial caries lesion, or insufficient caries lesion. This does not have great demineralization that can be detected on a radiograph. So this is a caries lesion which can be seen clinically but cannot be detected on a radiograph, is initial caries lesion or white spot lesion or insufficient caries lesion. Or caries lesion which is seen radiographically but cannot be seen clinically is hidden caries or occult caries, or your fluoride bombs or your fluoride syndromes. I hope you guys are very, very clear with both of these concepts. Okay. These questions are already given. Few of them are already given. Okay, they are not self-made, they're already given. So I'll try to cover as many questions as possible from all the subjects. Okay, the next one I want to talk about the papillary carcinoma of thyroid is Psammoma bodies. Okay, so this is the Psammoma body, which is a basophilic body. They can give a histological diagram from general pathology also. Psammoma bodies are most commonly seen is my code is pap smear. Okay, the most common question for us related to this Psammoma bodies is papillary carcinoma of thyroid. Apart from papillary carcinoma of thyroid, it can be seen in pituitary adenoma. It can be seen in the serous cystadenoma of ovary, and all the other examples do make a note. It is the most commonly asked question for is papillary carcinoma of thyroid. Psammoma bodies are seen in which of the following carcinoma of thyroid? The answer is papillary carcinoma of thyroid. It is a basophilic body. The other important area I want to stress on is I want to integrate with general pathology. What is general pathology? General pathology, you have types of calcifications that most of us are familiar. One is dystrophic calcification. Second one is metastatic calcification. Whenever I'm talking about dystrophic calcification, I always told you to remember D. D for D. Dystrophic D, dead and degenerated. Calcifications which are seen in dead and degenerated structures are called as dystrophic calcifications. D for dead, D for degenerated. Okay, your Psammoma bodies is a which type of calcification is your general pathology question. Okay, Psammoma bodies are which type of calcification? They are dystrophic calcification. So I'm jumping into endo. Okay, pulp stones. Pulp stones classifications and everything like denticles, true pulp stones, false pulp stones, embedded pulp stones, free pulp stones. Lots of things we have discussed related to the pulp stones. Now my question is, this is not there in general path. This is from endo. Which type of calcifications you see in pulp stones? Pulp stones are which type of calcifications? Pulp stones are basically dead and degenerated associated. They are dystrophic calcifications. Okay, Psammoma bodies is dystrophic calcification. Pulp stones are dystrophic calcifications. Dystrophic calcifications are basically the concept is seen with dead and degenerated cells. Okay, I want to close from here. Okay, so now you have a question. Which of the following characteristic is not true regarding the papillary carcinoma of thyroid? Which of the following is not true regarding the papillary carcinoma of thyroid? The first statement is papillary carcinoma often exhibits a mix of papillary and colloidal filled follicles. Yes, I told whenever you have papillary, you consider it as papillary carcinoma of thyroid. The next option B, okay, jumping into option C, whatever we have discussed. It is orphan annuli nucleus is very commonly seen in histology. Yes, perfectly right. We have already discussed it. Lymphatic spread to the lymph nodes is common in papillary carcinoma of thyroid. Yes, we have learned papillary carcinoma means L and L. One L talking about lungs, second L talking about lymph that we have discussed. Okay, it is very rarely, papillary carcinomas are very rarely encapsulated. Okay, right. So this is a false statement. The answer is B. I hope you're clear. Then jumping into our best friend, follicular carcinoma, right? Follicular carcinoma, ameloblastoma, right? Follicular, whenever I'm asking a dental student about follicular, first thing that strikes their mind is histological types of ameloblastoma. The most common histological type of ameloblastoma is follicular follicular type. Okay, but when I'm talking about thyroid, okay, the most important thing that you have to make a note when I'm talking about follicular is F. FNAC is contraindicated in which of the types of histological types of thyroid carcinomas. Blindly, you can go for FNAC, F, that is follicular carcinoma of thyroid. FNAC is contraindicated. Reason why is whenever you do FNAC for follicular carcinoma of thyroid, you cannot differentiate carcinoma from adenoma. Reason is, okay, carcinoma cannot be differentiated from adenoma because you have a term called as follicular adenoma. You have a term called as follicular adenoma. So follicular adenoma and follicular carcinoma cannot be differentiated. That is the reason why FNAC is contraindicated in the follicular carcinoma of thyroid. The next important thing I want you to make a note is, there I told you to remember L and L. Here I am asking you to remember B and B. Okay, B for blood, B for bone. Metastasis is first metastasis organ is bone. Okay, metastasis occurs through blood, and treatment is near total thyroidectomy for follicular carcinoma. Then jumping into other important carcinoma of thyroid where n number of questions can be coming from a dental student along with the histology. Most common histological diagram for us for a thyroid carcinoma is papillary. The second most common they can ask is directly to the medullary. Okay, I told you, right? This is again from B and L. Please do make a note. Okay, so jumping into medullary carcinoma of thyroid. Medullary carcinoma of thyroid is basically originated from the parafollicular cells. The origin of the parafollicular cells is from the neural crust cells. So these parafollicular cells, which are also called as C cells, they are going to secrete a hormone called as calcitronin. And of course, when I'm jumping into histology, what you can see amyloid stroma, and similarly you can see cell balls also in the histological diagram. Okay, so amyloid stroma is a very peculiar term that is given for medullary carcinoma of thyroid. Whenever they're talking about calcitronin levels are increasing in which of the thyroid carcinoma, medullary carcinoma. And M for men. Okay, medullary carcinoma is most commonly associated with Men's syndrome. And E for Rett gene question is a very, very frequently asked. Okay, again, general pathology. Rett gene is associated with which of the carcinoma of thyroid? The answer is medullary carcinoma of thyroid. So apart from increasing in the calcitronin levels, in B and L it is mentioned as, it is clearly mentioned there is increasing in the cranioembryonic antigen. Okay, so they can ask this particular question also straight away line from B and L. So you know that this is a tumor. Whenever the tumor cells increase, the tumor cells are going to produce prostaglandins. They have clearly mentioned they produce other substance called as 5-hydroxytryptamine, which is the main reason for occurrence of diarrhea. Diarrhea is very commonly associated with medullary carcinoma of thyroid. Diarrhea, whenever they give thyroid carcinomas talking everything and telling some signs of diarrhea, you have to think about the keyword of diarrhea leading to medullary carcinoma of thyroid. Very important aspect is parafollicular cells or C cells which secrete calcitronin. These are originated from the neural crust cells. The last one is anaplastic carcinoma of thyroid. So all the carcinomas, whatever we have discussed till the point, that is papillary, follicular and medullary, all these are differentiated carcinomas. When jumping into the last one is undifferentiated carcinoma of thyroid, which is anaplastic. Undifferentiated carcinomas are more dangerous. Okay, more dangerous, right? So which of the following carcinoma of thyroid is more dangerous? Your answer is anaplastic carcinoma of thyroid is more dangerous because it is undifferentiated. That is the reason why it is more aggressive. It spread, the first organ it spreads is lungs. Okay, so these are the important points that I want you to make a note. And similarly, the mode of spread is by direct invasion. Okay, so we have discussed, right? We are discussing like what is the mode of spread of basal cell carcinoma. Normally, most of the carcinomas, they spread either by lymph or blood, whatever we have discussed until now. And you see basal cell carcinoma is something which spreads by direct invasion. So similarly, anaplastic carcinoma also spreads by direct invasion. But that is very specific to the to the early future. Okay, it is an early feature, and followed by that it spreads by both lymph and blood. Okay, it spreads by both lymph and blood. I hope you guys are very, very clear regarding this particular point. Direct invasion is the early phase, followed by the spread can occur either by lymph or blood. And in most of the situations, this is firm and white. And FNAC is going to show giant cells and multinucleated giant cells, multinucleated giant cells, general pathology it shows. Sometimes they can tell you long-standing neck masses as an etiology. Long-standing neck masses as an etiology can lead to anaplastic carcinoma. Anaplastic carcinoma, I told it is very dangerous. It is lethal. The survival rate after diagnosis will be within months, and the mean value that is given in B&L for this is 3 months. For this is treatments. And the treatment of this particular carcinoma is completely symptomatic. Basing upon the symptomatic, you start the therapy. Sometimes if you don't have symptomatic in the options, you can think about radiotherapy. Okay, right. You can think about radiotherapy. Guys, I hope you're very, very clear till this point. Okay, I'm done with thyroid carcinomas. Being a dental student, I hope okay, anyway, it is on social media, so I want this class is exclusively only for dental students, exclusively for the dentists. Okay, right? The point is, most of us in our I mean, like being a dental student, I'm into dentistry for 18 years, into dentistry in 18 years. So in this 18 years, in my college life, if you're talking about thyroid, I was exposed to a thyroid patient. Number one is, luckily, I got thyroglossal ductal cyst. I have seen thyroglossal ductal cyst. So that is the reason why I remember everything clearly. Okay, and talking about thyroid, maybe I have seen some small thyroid nodules, but I really don't know the diagnosis at that time. But none of the thyroid carcinomas, as far as I remember in my general surgery wards or in my exposure, I have not seen. And I strongly believe that most of you may not have the exposure. Anyone has any sort of thyroid abnormality exposure apart from a regular thyroid swelling, goit or something, or similarly, like luckily I have seen thyroglossal duct cyst. Does any one of you, like I see like more than 200 odd students are there live? Any one of you have seen any such cases in your career? So my concern is, whenever you're reading concepts, I want you to try to integrate the concepts. One second thing, try to revise them and again. For example, throughout my life, apart from teaching, even if I don't teach, throughout my life, I still remember this thyroglossal ductal cyst because I have seen the case. Okay, whenever you have seen some things, you can recollect. That is the reason why reading dental subjects is going to be more easy. For example, you see a mandibular fracture in an oral surgery clinical posting, you can easily understand some basic points related to the mandibular fracture, some basic points related to the dry socket. You see dry socket, you can easily understand dry socket. You see a syncope patient on a dental chair in oral surgery wards, yes, you can easily answer. You see a pregnant woman, how you handle, you can easily answer. So this comes with exposure. But during our preparation phase, which cannot be modified, we are not exposed to majority of the clinical cases of general path as well as general medicine. General medicine is something like a nightmare for most of us. So my concern is, whenever you read, try to integrate, try to revise them, try to write some short notes like this and try to revise them and try to get a good command over the subject, which is very, very much required for entrance exams to be in the top list of any entrance examination. Okay, or let it be you're going for a international license exams or PSC exams. Okay, to crack these exams, you should have a knowledge command over all the things, all the basic things at least. Okay, right? Okay, so most of you are telling no exposure, but okay, let's try to learn, at least try to write the decent things from the standard textbooks, and within a shorter time, try to revise them again. That is a beautiful suggestion what I can give. We can do better. Don't worry, we can do better. No, even if it is not exposed, you repeatedly do 2 or 3 times. I feel like as a doctors, as we are inclined to crack this entrance exam, okay, working hard to crack this entrance exam, I hope we can achieve this, not an issue. Okay, so a little bit of questions from your blood transfusion. Okay, blood transfusion is a very, very important topic in your general surgery. Okay, so red blood cell transfusion is indicated when the hemoglobin level is, red blood cell transfusion is indicated when the hemoglobin level is less than 7 gram per deciliter. Whenever it is less than 7 gram per deciliter, okay, your blood transfusion is indicated for such an individual. And one unit packed RBC will raise the hemoglobin levels by 1 gram per deciliter. 1 gram per deciliter. Hematocrine by 3 to 5%. 1 unit of packed RBC contains dash amount of iron. It contains 200 to 250 milligrams of iron. It contains 200 to 250 milligrams of iron. Okay, right. I hope you guys are familiar with these things which are already discussed for you. And 1 unit of platelets increase the platelet count by 10,000. 10,000 platelet count by 10,000. Prophylactic transfusion in acute leukemia can be done if the patient platelet count is less than 10K. It's less than 10K. And similarly, a similar question was given for us in Neet 2024. But that is not basically leukemia. The question was, below which value of platelet count elective surgical procedures are contraindicated in dentistry is a question that is given in Neet 2024. I'm not very clear about the options which are given in the exam because I see students are giving different options, but straight away this question was given. A patient with some platelet abnormality has been in the OPD where we need to start an elective surgical procedure. Okay, so what platelet count is a deadline for us? Okay, so this beautiful classification was given in your McDonald pedo standard, most standard textbook. Okay, so it was clearly given, these lines were clearly given. What are these lines? Whenever you have a platelet count of 20 or 50K, 20,000 to 50,000K, this is considered as moderate risk of bleeding where elective surgical procedures are not encouraged. And whenever you have a platelet count of less than 20K, then here you have a significant risk of bleeding. One is moderate risk, 20 to 50K, moderate risk, less than 20K, significant risk. In both of these conditions, the procedures are contraindicated. So whenever your platelet count is less than 50,000, okay, your procedures, elective surgical procedures are contraindicated in those individuals. Okay, right. I hope you're very clear about this. Okay, right. So jumping into the next one, which of the following is the mutation associated with the microscope image, which is a microscopic image of thyroid shown below. Microscopic image of thyroid shown below. This we have already discussed. What is that? BRAF V600E. BRAF V600E is a condition. Okay, this is your INICET, recent INICET 2024 question. Okay, right. So can you tell me what is RET? What is RET? RET gene is associated with. RET gene is associated with which of the carcinoma? RET gene is associated with which of the carcinoma? So RET gene is associated with which of the carcinoma? RET gene is associated with medullary carcinoma. Very good. So, okay, right. So you have RET gene mutation is associated with medullary carcinoma, whereas BRAF is associated with papillary carcinoma of thyroid. Okay, here you can see what is this histological diagram. What is this histological diagram? Most of you are familiar. Yes, this histological diagram is orphan annuli nucleus, which is seen in the case of papillary carcinoma of thyroid. Okay, the next one is a 50-year-old woman is diagnosed with papillary carcinoma of thyroid. Which of the following histological feature is the most common characteristic feature of this type of carcinoma? Most of you are familiar. This is orphan annuli nucleus. Okay, now I want to talk a little bit about FPP. What is FPP? FPP is frozen fresh plasma. Okay, frozen. The word itself tell it is frozen, so it has to be frozen. Okay, right? It has to be stored at a temperature of minus 18 degrees centigrade. What does it contain? It contains stable coagulation factors, and the shelf life of this is 1 hour. The shelf life of this is 1 hour. Okay. And the plasma proteins that it's going to contain is fibrinogen, antithrombin, albumin, and protein S and C. So these are the contents which are present in your FPP. These are the contents which are present in your FPP. So they can ask you 1 unit of FPP. 1 unit of FPP is going to contain what? 1 unit of FPP is going to contain 400 milligrams of fibrinogen and 1 unit activity of each of the clotting factor. Very, very important question is indications of FPP. Indications of FPP. One of the most common indications, of course, it can be used in coagulopathies. One of the most indication of FPP, if vitamin K is not offended, is not available for you, because vitamin K is a drug of choice in the case of warfarin toxicity. Whenever you want to reverse the warfarin effect, or whenever you want to treat warfarin toxicity, the drug of choice that has to be given is vitamin K. Okay. So if vitamin K is not available, you can try FPP. Okay. Can you tell me what are the factors which are associated with vitamin K? Can you tell me what are the factors which are associated with vitamin K? Can you tell me what are the factors which are associated with vitamin K? Yeah, vitamin K factors, associated vitamin K factors are 2, 7, 9, 10, protein S and protein C. 2, 7, 9, 10, protein S and protein C. These are the factors which are associated with vitamin K. Okay. So FFP can be used in the reversal of warfarin effect, and it can be used in the treatment of TTP. So then we need to talk about the cryoprecipitate. Again, cryo means cold. Okay, so same, we are going to store it at a temperature of less than minus 18 degrees centigrade. And this is going to contain fibrinogen, factor number 8, clotting factor number 8. It's going to contain von Wille factor. And a very, very unique important point that you have to make a notice. Ideal for supplying the fibrinogen when the patient is volume sensitive. So this is a very ideal case. In ideal case, because fibrinogen is present both in FPP as well as in the case of cryoprecipitate, whenever the patient is volume sensitive. Okay, in such conditions, what you have to prefer is you have to prefer cryoprecipitate rather than FPP. So coming to 1 unit, this 1 unit is going to contain 800 to 145 units of factor 8, and it's going to contain 250 milligrams of fibrinogen. One disadvantage of cryoprecipitate, because basically we are going to obtain cryoprecipitate from a larger group of patients. Okay, cryoprecipitate from larger group of patients. And apart from this, cryoprecipitate is going to contain cells. So that is the reason why cryoprecipitate can transfer the infectious diseases, whereas FFP will not transfer the advantage of FFP is it does not transfer the infections, whereas cryoprecipitate has high chances of infections that is being transferred from the donor to that of the acceptor. Okay, right? I hope you guys are very, very clear with this concept. Okay, right? FFP. Done? Done, guys? Yeah, this is shelf life is 1 year, sorry. Shelf life of FFP is 1 year. So we are done with 14 indications of FFP and 15 what are the contents of cryoprecipitate. Then jumping into question number 16. A 68-year male patient in post-operative recovery unit receives a transfusion of 3 units of packed cell RBC due to significant blood loss during the surgery. What is the next appointment in managing the patient? A similar question was given in your for us in the examinations. The thing is, you have to stop the transfusion immediately, and you have to inform to that of the physician. Okay. So now we'll be talking about some of the complications that are associated with blood transfusion. Okay. So most important complications that we have to address whenever we are having a blood transfusion is anaphylactic shock, atopia or anaphylactic shock, which is a type 1 hypersensitivity. These conditions may be immediate. Okay. So what you have to do whenever you have atopy or anaphylaxis is, what is the drug of choice for anaphylactic shock? A recent, very frequent Inicet and Neet question is, you have to give adrenaline. You have to give adrenaline. Adrenaline is the drug of choice for this anaphylactic shock. Okay, right. So apart from the anaphylactic shock, there are two other important conditions that we have to address. Okay, whenever you have a blood transfusion related reactions. One such condition is TRALI. Okay, what is this TRALI? Transfusion related acute lung injury. So it is related to lung. Okay, it is related to lung. What is that lung injury? That lung injury is basically ARDS. Okay, acute respiratory distress syndrome. So this acute respiratory distress syndrome can be diagnosed with the help of a radiograph. So on an X-ray, on a chest X-ray, you can see a bilateral infiltration that gives a diagnosis of ARDS. Whenever a blood transfusion with a bilateral infiltration on a chest X-ray, your answer is ARDS associated with TRALI. Mostly this TRALI will occur within 6 hours, and the most common etiology for occurrence of this TRALI is, okay, HLA antibodies. It is because of cross reaction of the HLA antibodies during the blood transfusion. The second important condition that occurs is TACO. Okay, TACO, CO regularly. CO is cardiac overload or cardiac output overload. Okay, so this is transfusion associated cardiac overload. Whenever you have a cardiac overload, a very common thing that we regularly see is pedal edema. You see, like cardiac patients in the home, they have their pedal edema, they have their puffiness of the face. Okay, of course, cardiac output is increased, breathlessness will be there, but here the X-ray will be normal. So how to differentiate a TACO and a TALI is by taking a chest X-ray. If the chest X-ray is normal, then it can be TACO. If the chest X-ray is bilaterally infiltrated, then it can be TRALI. So what is the treatment of cardiac overload? Whenever your cardiac overload is there, what is the drug of choice? Your drug of choice is diuretics. You're going to give furosemide, by which the cardiac overload can be minimized. So most important thing is anaphylactic shock. The drug of choice is called as adrenaline. Okay, whereas TRALI is associated with ARDS. Okay, respiratory distress syndrome, by which you can see as a bilateral chest infiltration. You're going to give the respiratory support to the patient. TACO is cardiac overload, where you have a normal X-ray. To decrease the cardiac overload, we are going to give diuretics. The furosemide is the drug of choice. I hope you guys are clear with TRALI and everything. Next, jumping into massive blood transfusion. Okay, so definition of massive blood transfusion and the complications that are associated with massive blood transfusion are again a very, very frequently asked question. So what is definition of massive blood transfusion? On which we have questions is, when the whole blood of the individual when whole the blood of individual is transferred within 24 hours, or 10 units is transferred within 24 hours, or 4 units are transferred within 1 hour. Any of these condition is called as massive blood transfusion. Any of these condition is called as massive blood transfusion. Okay, any of these condition is called as massive blood transfusion. Then jumping into blood transfusion related complications. Okay, so we have already discussed majority of the complications. Okay, the most common complication is FNHTR. That is non-hemolytic transfusion reaction. That is non-hemolytic transfusion. The other things are allergies can be seen. Normal allergy can be seen. Sometimes anaphylactic reaction can be seen. Okay, and of course we have discussed about TRALI. Hemolytics can be seen. A delayed hemolytic or acute hemolytic or fatal hemolytic reactions can be seen whenever you have a transfusion. Then come infections. Very common infections that we have to make a notice. Hepatitis, because hepatitis is again a very important topic for us from any subject, from medicine point of view or from microbiology point of view. So the most type of hepatitis which is most commonly transferred by blood is B and C. B and C are blood transfusion related. Blood related. And can you tell me fecal oral? Hepatitis which are transferred by fecal-oral. Types of hepatitis which are transferred by fecal-oral are A and E. Hepatitis A and hepatitis E, the mode of transmission is by fecal-oral, whereas hepatitis B and hepatitis C, the mode of transmission is by blood. So you have to be very, very careful whenever you are going for blood transfusion. Of course, HIV and all these can also be transferred. Then I'm talking about the complications of massive blood transfusion. We have already discussed whenever you have a massive blood transfusion, there will be fluid overload. Okay, there will be hypothermia, very important, hypothermia will be there. So this concept we will be discussing in the case of your respiratory system oxygen dissociation curve. So whenever there is a massive blood transfusion, it impairs the oxygen delivery capacity of the hemoglobin, thereby decreasing the 2,3 dpg in your oxygen dissociation curve. And electrolytic related complications are very important that you have to make a note. Okay, so there will be decreasing the calcium, decreasing in the magnesium, but increasing in the hyperkalemia can be seen. And apart from this, you can see metabolic alkalosis also. Okay, so these are complications associated with the massive blood transfusion. These are complications associated with the massive blood transfusion. Right. So now the question is, whenever you have a blood transfusion, what is the best thing to be done? How do you replace it? Whenever you have a blood loss, the best thing is to replace the blood is with blood. But in most of the conditions, the blood may not be available immediately. Okay, because we need to go for some cross matching and then we have to take a call regarding the blood transfusion. So what happens here, the immediate solution that is available for us is Ringer lactate. So you can give Ringer lactate. Ringer lactate is also called as Hartmann's solution. You can give the Ringer lactate, which is a crystalloid solution, or you can give normal saline also, but Ringer lactate is going to be the best option. To transfer blood is the best option. If you don't have blood, then you can think about Ringer lactate, which is also called as Hartmann's solution. So then jumping into question number 20, in the setting of acute hemorrhage, the ratio of packed RBC, FFP and platelets is, it is 3:1:10. 3:1:10. Okay, so please do make a note of it, memory based. 1 unit of blood means 1 unit of blood is 350 ml. 1 unit of blood is 350 ml. 1 unit of blood is 350 ml. Next one, 1 fist of blood means 1 fist of blood means just a second. Yes, 1 fist of blood is 500 ml. 1 fist of blood is 1 fist of blood is 1 fist of blood. Okay, where they are going to ask you 1 fist of blood is like, for example, there is one question which is given for the Neet PG for the medical friends. So they're going to mention a surgical procedure is happening, and they're going to tell you that they have used some 100 or 200 ml or some 500 ml of irrigation during the procedure. And they're going to tell you the amount of liquid that is being collected in the suction. And they're going to tell you the clot when they're describing the clot. So whenever there is a surgery, clot can be formed. Okay, trauma or clot can be formed. They can tell you 1 fist of clot. So whenever they're talking about 1 fist of clot, they're mentioning the size of a clot. 1 fist of clot means how much amount of blood is there in that 1 fist of clot is 500 ml. So when they're giving such a situation, so they can ask you what is the amount of blood loss during this procedure. They can ask you. Okay, in such a conditions, you have to calculate all these values. What is going inside, what is coming outside, what is lost in the middle. So that is going to be the amount of blood that is lost. 1 mop of blood. Sometimes they keep mops and they take mops out soaked with the blood. So what is one mop of blood? What is one mop of blood? One mop of blood is, yes, one mop of blood is 100 ml. And lifespan of RBC and platelets are a very frequently asked question. Lifespan of RBC is 120 days and lifespan of platelets is 7 to 10 days. And conditions like sickle cell anemia where the lifespan can be decreased. For example, if they're asking the lifespan of RBs in the case of sickle cell anemia, it is around like 20 to 30 days according to the references. It is less, lifespan will be less in the case of sickle cell anemia. Okay, lifespan will be less in the case of sickle cell anemia. Next, maximum life of transfused RBC is. Maximum life of transfused RBC is 50 days. Next, platelets are stored at what temperature? Platelets are stored at room temperature. That is, platelets are stored at 20 to 25 degrees centigrade for 5 days. Platelets are stored at 20 to 25 degrees centigrade for 5 days. Okay, right. I hope you're clear. So platelets in a stored blood become non-functional after how much time? Platelets in a stored blood will become non-functional after 24 hours. Half-life of factor 8 is again a repeat. Half-life of factor 8 is 8 to 12 hours. Fresh whole blood transfusion is done within how much time of collection? 24 hours. And of course, we have discussed about the complications of blood transfusion, massive blood transfusion or anything. C for decreasing in the calcium levels. A for alkalosis. T for temperature, less temperature. Hypothermia we have discussed. C for citrate toxicity. And H for hyperkalemia. Okay, you can remember it as catch. You can remember it as catch. And other important aspect, whenever you have done a mistransfusion, okay, again, these are series of questions which are given. Whenever there is a mistransfusion and if you are injecting a wrong blood group to a patient, what is going to happen? In a normal condition, what can happen to the patient is there will be heat and pain at the site of transfusion. Okay, wherever you're keeping the transfusion, what is going to happen? There will be severe heat generated and pain at the site of injection. And whenever you're talking about signs, what signs you can see is oliguria or hematuria you can see in those individuals. But during the surgery, if you are giving a wrong blood, then what is going to happen is there will be hypotension and bleeding at the site. At the open site, wherever the open site is there, in normally body will have hypotension, but there will be severe bleeding at the site of surgical procedure. So check whether they're asking surgical procedure or whether they're asking a normal condition, because both of them are previously given as a questions for us. Guys, clear? Can I proceed with the next concept? Hemorrhages. Last 5 years, 3 or 4 times a question on hemorrhages was given. So, right, okay. So jumping into hemorrhages, okay, hemorrhages are basically categorized into primary hemorrhage, reactionary hemorrhage, secondary hemorrhage. Primary hemorrhages are something which occurs at the time of surgery, at the time of procedure. Okay, hemorrhage which occurs at that time are primary hemorrhages. Second one is reactionary hemorrhage. Reactionary is reacting. Okay, so reactionary hemorrhages can occur within 24 hours. For example, there is a loss of clot after the procedure. After some time, there is a loss of clot that leads to hemorrhage, that is called as reactionary hemorrhage. Or it can be you kept a suture or you kept a knot. There is a slippage of the knot. There is slippage of the suture. That can start the bleeding. That is called as reactionary hemorrhage. And hemorrhages which occur over a period of time, preferably in the textbook it was given as 17 to 14 days. Such hemorrhages are called as secondary hemorrhages. Okay, this is a simple basic definition. Okay, now you have a question number 31. A 60-year male patient undergoes surgery for a larger abscess. Post-operatively, he is monitored for any signs of bleeding. 8th day following the procedure, the patient experiences significant bleeding from the surgical site. In evaluating the potential cause of bleeding, this is which type of hemorrhage? The keyword in the question is 8 days. When you see the keyword in the question is 8 days, okay, what is your answer? I told you 17 to 14 days. Whenever you see range of 17 to 14 days, okay, your answer should be secondary hemorrhage. Very simple. Your answer is secondary hemorrhage. Very simple, right? So whenever you have a lengthy, so this is okay, 1, 2, 3, 4, some 5 or 6 lines in the examination. So whenever you have lengthy question, don't get panic. Okay, you try to read and identify the keyword in the question. Like now the exams are not on paper. Okay, right? So whenever we used to have, like when I have given the entrance exam, our exam is on paper exam. Okay, so whenever I'm giving an on paper exam, I carry a pen. They are going to give you a pen or a pencil or something. I carry a pen, and while reading, I try to underline the keywords. So with the help of keywords, we are going to conclude the answer. But now it is a digital exam. Okay, you're going to give an exam on a computer. So now the keywords underlining should be done by the brain. Okay, you have to underline the keywords 3-dimensional in the brain. Okay, 8 days is the keyword. So 8 days is giving the answer. Done. The question will not take much time if you underline the keywords. And whenever you have a question, I told you, like whenever you have a lengthy question, I told my students to check out the last line of the question. So what is the last line? This is which type of hemorrhage is the last line. And you see 8 days and which type of hemorrhage? Yes, the answer is secondary hemorrhage. Without seeing the options also, you can go for the answer is secondary hemorrhage. Next, you have one more question. A 45-year-old male patient underwent an electrical abdominal surgery without any complication. 8 hours post-operatively, the intern informs that the surgical resident that the patient has 800 cc amount of blood collected in the drain. They are going to attach a drain, positive pressure drain or any sort of drain will be attached for the leakages and everything. Basing upon the timing and the volume of the drain is what type of hemorrhage it's most likely to be. Here the keyword of the question is 8 hours. 8 hours means less than 24 hours. 8 hours less than 24 hours, your answer is reactionary hemorrhage. Your answer is reactionary hemorrhage. I told reactionary hemorrhage is something which occurs within 24 hours. Which occurs within 24 hours. Okay, right, clear, very good. Then I'm jumping into, yes, of course, it's not mandatory when you're reading general surgery, but sometimes they can give a 1 or 2 bouncers related to the abdomen or related to the pelvis or related to the lower limb. I still remember 2024. It's okay. They're tough questions, but most of the questions were moving around our knowledge. Okay, but in 2023, there was a question in general surgery related to the lower limb. Okay, related to the lower limb. It's a basic question. It's not tough question. It's a basic question. The question is on compartmental syndrome. Which is related to the lower limb. But in majority of the situations, most of the questions of GS, particularly when I'm talking about Neet, okay, will be within our zone. There's nothing to worry about. It will be within our zone. Okay. So we need to make a note about this triads, which are most common, triads and pentads, which are most commonly associated with acute cholangitis. Okay. So Charcot's triad, where you have 3 significant things. Yeah, 3 significant things. One is your right upper quadrant pain. You will have jaundice. You will have fever or chills. So this is a triad which is specifically associated with acute cholangitis. And you have Raynaud's pentad Apart from this triad, you are going to have two other things. Okay, you have two other things which make it as a pentad. What are the two other things? The two other things, one is hypotension, second one is mental confusion. Okay, the two other things which are added to the pentad is hypotension and mental confusion. Okay, triad is basically right upper quadrant pain, jaundice, fever or chills, and the fourth factor and the fifth factor for the pentad is hypotension and mental confusion. I hope you guys are very, very clear with 33. Then I want to talk a little bit about ulcers. Already we have done ulcers. Whatever the recorded video we have on the ulcers is from SS Das. Directly I have taken from SS Das. But that's what I'm telling. Like there's a few overlappings. The concept overlappings will be there from textbook to textbook. To remove those confusions, okay, I'll try. This is from B&L. I have taken B&L, latest edition of B&L. So most of us are familiar about ulcers and their edges and everything. So this diagram is basically, because this cross-section diagram is also given in the exam. The first one that most of us are familiar are sloping ulcers, shoveling ulcers. The second one is undermined. You can see an undermined here. So the second one is undermined ulcer, which is most commonly seen in the case of TB, that most of you are familiar. TB ulcer is undermined ulcer. The third one is rolled. You can see the word rolled and may exhibit small blood vessels. Then your answer is rolled. Whenever you see rolled, basal cell carcinoma is the best one. Sometimes what you can see, rolled averted they can ask. Rolled plus averted they can ask. Whenever you have rolled plus averted is squamous cell carcinoma. Okay, the next one is punched out syphilis. Punched out, you can see punched out edge with thin base, and the base is covered by washed leathery slug. That is very, very specific feature that is seen in the case of syphilis. Okay, right, clear? Sometimes rolled, if they're asking only rolled, go for basal cell carcinoma. Rolled plus averted, squamous cell carcinoma, or only averted, squamous cell carcinoma. Punched out, syphilis. Undermined, TB. Okay, right? Very, very important. I have given the other examples are there. Other examples are also there. But these are the most common examples. 95 to 99%, these are the areas where they are going to give question. Most common example is the area where they are giving question, and it was already given so many times in the exam. We'll try to discuss other punched out. Other punched out can be seen, like yesterday we have discussed punched out interdental crater-like depression. Punched out interdental papillae, crater-like depression, very frequently asked question, ANAC. Even punched out can be seen in other oral lesions, that is aphthous ulcer. Okay, irregular punched out, radiographic signs and everything. We'll be discussing that today in today's evening session. Okay, but as of now, I want to close it. Rolled, BCC, averted, SCC. Rolled plus averted if they're giving, go for SCC. Punched out, syphilis. Punched out crater-like depression of interdental papillae, ANAC. Undermined edges are seen in the case of TB. Sloping edges are seen in the case of healing ulcer. I hope this is very, very clear. So apart from this beautiful classification from B&L, there is one more classification in B&L that I want you guys to make a note. The classification of common types of ulcer in B&L. In this, broadly, they have divided the ulcers into three categories. I'll try to make this table as simple as possible. One is non-specific ulcer. There is no reason. Second one is specific ulcer. Third one is malignant ulcer. Specific ulcers are basically associated with infections. They have a specific infection causing a specific ulcer. So most of the primary infectious agents, that is your viruses, herpes simplex, or your bacterial, that is your TB or syphilis or fungal, are going to cause specific. These are primary infections. Whenever it is secondary infections can occur anywhere. Like I have a trauma, I have a healing process, and during the healing process again it was infected. That is called a secondary infection. It is not specific. But when I'm talking about a TB ulcer, it is specifically caused by TB. I'm talking about a syphilis ulcer, it is specifically caused by syphilis. So primary infectious ulcers are called as specific, whereas secondary infectious ulcers are called as non-specific. One of the infection ulcer which comes under non-specific is leprosy. Leprosy is an infection. But most of the ulcers in the leprosy are neuropathic ulcers because of the damage to that of the nerve. Neuropathic ulcers will be coming in leprosy, which are nowhere related to specificity. They are called as non-specific ulcers. Guys, clear? And sometimes you have malignant ulcers also. Okay, malignant ulcers also. Your basal cell carcinoma, your squamous cell carcinoma, these are called as malignant ulcers, which can be seen in the case of GIT also. GIT also, malignant ulcers can be seen. Okay, that is the reason why they have given skin. Skin is nothing but called as squamous cell, basal cell carcinoma are malignant ulcers. Apart from this, GIT ulcers also comes under malignant ulcers. Guys, clear? Clear, right? Non-specific, which does not have any specificity. The only exception I want you to make a note is leprosy, which comes under neuropathic ulcer, non-specific. Whereas the rest other primary infections, it is specific. TB, syphilis, or fungal infections, or viral infections, or anything. And jumping into the next part is malignant ulcers are skin ulcers and GIT ulcers. This is one more classification of your ulcers that you have to make a note according to B and L. Okay, and I feel, I strongly believe that I'm very, very confident about this because my professor during general surgery wards, every day we used to have discussions, lots of discussions. He has shown lots of ulcers to us. Okay, luckily, we have patients, and we have seen. And I don't know about you guys whether you got exposed to all these things. So one is, how do you do this? A base of an ulcer and floor of an ulcer. Okay, which you can feel, which you can see, which you can feel, which part of ulcer can be felt. You can feel, you can palpate which part of ulcer, and you can see which part of ulcer. I want your response, guys. Yes, base is palpated, base is felt. Okay, whereas floor, you can see the floor. Okay, you can see the floor, right? Right. So what is the definition of floor of the, what is the definition of floor of the ulcer? Okay, let's start with base. Base of the ulcer is, I feel, I palpate the base of the ulcer. Okay, whereas the floor of the ulcer is the part of the ulcer that is exposed. The part of the ulcer that is exposed or seen is called as floor. We'll talk about different types of floors, very common examples, and I hope you can easily handle it. Red granulation tissue. Red granulomatous tissue is seen in the case of healing ulcer. Healing ulcers are red in color. Necrotic, dead necrotic slogs are seen in the case of spreading ulcers. Spreading ulcers. Pale, scanty granulation tissue is seen in the case of TB ulcers. We have learned a lot about TB ulcers in the last 3 or 4 days during our activities and everything. We learned lots of TB ulcers. Okay, TB ulcer is painful ulcer. Is it painful? Yes, TB ulcers are multiple and they are painful. Okay, Neet 2018 question, which of the following ulcer is painful? The answer is TB ulcer. Okay, so TB ulcers are seen on tongue in the oral cavity, and they are multiple and they are painful, and they give a tagline like it's not like rodent ulcer. Rodent ulcer is basal cell carcinoma. In TB ulcers also they give a tag like rat eaten. Rat, it looks like a rodent. It's not, they don't use the word rodent. It like they'll tell rat eaten, like rat bite like ulcers which are seen in the oral cavity are TB ulcers. They are multiple and they are going to be painful. And of course, so many times repeated in the exam till the date, washed leathery slug is seen in the case of gamma ulcer of syphilis. Syphilis is one of the most common area of questions. Every year you have at least one question on syphilis. Even in last NEET 2024, you have a question on tests of syphilis microbiology. Before last year, you have a question on syphilis teeth. Moon's molars are seen in which type of syphilis was a question. So before that year, you have a punched out ulcer is seen in which type of infection syphilis. Syphilis question is mandatory in the exam. HIV question is mandatory in the exam. Hepatitis question is mandatory in the exam. TB question is mandatory in the exam. Okay, right? So we have already done. Okay, so one is floor. Granulation tissue is non-specific healing. Slog we see in infectious ulcers. And we have already discussed what is the TB of skin called as? Yesterday I was talking about TB of skin. Yes, TB of skin. TB of skin is called as lupus vulgaris. So in lupus vulgaris, what you regularly see is watery or apple jelly appearance. Watery or apple jelly, sometimes they call it as apple jelly bodies, are seen in TB of skin. They can give you TB. And what is the test that is used here is matchstick test. What is the test that is used is matchstick test. Of course, washed leathery slug is seen in the case of syphilis ulcer. And I have already discussed base, the part of the ulcer which is palpated, or the part of the ulcer which is felt. Induration is one of the important feature of malignancy. The most important feature of malignancy is not talking about ulcer, I'm talking in general. The most important feature of malignancy, to confirm malignancy, is the most important feature to confirm the malignancy is metastasis. It is metastasis. When I'm talking very specifically about ulcer, the most important thing is clinically you can check the malignancy is induration. Indurated base is seen in the case of. Sometimes your base is attached to the deep structures in the case of venous ulcers. Sometimes your base is attached to the venous ulcers. Okay, so this is all I want you to make a note when I'm talking about the basics of ulcer. Now we have a question on ulcer. A 55-year-old male presented to the clinic with a non-healing ulcer on the lower lip that has been presented for few months. The base is indurated base. So very nice keyword is given. The base is indurated. So whenever it is indurated, it cannot be syphilis, it cannot be TB, because whenever they're talking about the base of TB or floor of TB, they give a different features. Induration is a feature that is associated with malignancy. It cannot be traumatic also. So induration word is sufficient. It is malignant ulcer. The only one option in the malignancy is squamous cell carcinoma. We'll check out other options, whatever they're given. Rolled out, raised and averted. I told you rolled out is a keyword, very nice keyword for basal cell carcinoma. But you don't have basal cell carcinoma. Then other keywords are raised, averted margins. Raised, averted is squamous cell. So it is indurated, rolled, and it's a combination of squamous or basal cell, but whatever it is, by elimination, the answer is squamous cell carcinoma. And no need to wait to check out the leftover questions, leftover lines, okay, in such a question. The patient is a long time smoker. Smoking is associated with squamous cell carcinoma. Smoking is associated with squamous cell carcinoma. There no history of recent trauma or something. These are all nonsense, dummy lines. Okay. Indurated base is the keyword that is sufficient. By elimination, you can go for squamous cell carcinoma as an answer. Okay, clear, right? Means once you start doing more MCQs, exposing yourself to more MCQs, solving a question can be easy. Solving a question can be faster, means you can take less time to solve a question, and solving the question can be with more accuracy. Okay, so that is the reason why I always suggest the students to attempt more questions, to exercise more questions which are there on the website, because website is filled with lots of questions. Okay, 2026 batch, you have separate session called as Q bank, question bank is there, okay, where you have n number of questions on each topic, 20, 25, sometimes 30 questions are there. Make sure, take time, solve it, analyze it. If you have any doubts, 24/7 Srikanth sir is available for you. You can ping me so that we can discuss. If you have any doubts, we can discuss on the group, or we can discuss in the class, or we can discuss personally, not an issue. Okay, right, cello, I'm done with 34, jumping into the next important concept, ASA. I don't know how many of you had a surgical procedure till the date, GA, not very common, but yeah, at a UG and a PG level, I don't have, but recently I had a small surgery under general anesthesia. So I know this, like whenever you are going for general anesthesia, anesthetist is going to categorize you into a particular classes. Okay, these are those classes. Okay, one is ASA1, 2, ASA3, ASA4, ASA5, ASA. I'll try to focus on the most important areas rather than the examples. Okay. So ASA1 is something like a normal healthy individual. If you feel like a normal healthy individual, okay, for example, he has seen me, okay, he has seen me, and he has taken the basic history, and he told the surgical team he falls under ASA1. No complication. A normal healthy individual comes under ASA1. Next one, for example, even my father also had a surgery. He comes under ASA2. Okay, what is this ASA2? ASA2 is mild systemic diseases will be there. What are those mild systemic diseases? Any systemic diseases which are well controlled, well maintained, and everything is mild systemic diseases. Next comes is severe systemic diseases. Okay, the patient is having severe systemic diseases, high BP, very high BP, high glucose levels. All this comes under severe systemic diseases over a period of time. Those comes under ASA3. Coming to ASA4, a patient with severe systemic diseases and it is constantly life-threatening. He's not comfortable. He has abnormalities, he has stunts, he has everything. Okay, he is constantly life-threatening. That category of individual comes under ASA4. Then comes to ASA5. Very severe case, without a surgery, the patient cannot survive. Okay, that can be internal bleeding because of the increase in the intracranial pressure. They can have an internal bleeding, or there is a accident, massive trauma is there, or lots of things, multi-organ failure are there, ARDS, everything, anything can be life-threatening. If surgery is not done, the patient will die. So such categories comes under ASA5. And the last one is ASA6 is a brain dead patient. Okay, brain dead means the patient is already brain dead. Why we are using is we are using it for organ donation purpose. That category of individual comes under ASA6, and I hope you guys are very, very familiar about this ASA 1, 2, 3, 4, 5, 6. Okay, now you have the next question. A 64-year male is scheduled for hernia surgical repair. He has a history of controlled hypertension and type 2 diabetes managed by medication. Nice. He's a very good non-smoker. Reported no issues with the daily activities related to his health. Upon examination, the blood pressure and the glucose are found to be well maintained, and there is no signs of end organ damage. Basing upon the information given, American Association of Anesthesiologists classification, this person comes under which category? This person comes under which category? I told you ASA1 is healthy. He is not healthy. He has some problems, but which are well maintained, like my father. I told you, right? ASA1, my surgery is ASA1. My father's surgery is ASA2 because he has hypertension, he is diabetic, but they are well controlled and well maintained. Okay, the answer for this question is B. The answer for this question is B. Clear, right? Simple, right? Okay, chalo. Next one, which is the genotype with a blood group A phenotype? A very simple question. Genotype with blood group A phenotype. So I'll show you. Blood group A is going to have two genotypes. Okay, what are those two genotypes? IAA and IAO. Both of these comes under A. Similarly, BB, BO is going to be B blood group. AB is IAA, IB, and O is IO, IO. So these are the genotypes, phenotypes of the blood group. So A blood group is going to have two genotypes. B blood group is going to have two genotypes. AB and O are going to have only one genotype. So that can be in the form of a cross-linking also. It can be done from mother and father, how the genotype of an offspring can be. Okay, if the LI or the component which is given by mother is A, father is A, mother is A, father is A, then it can be IAA, which is IA, which is A blood group. It is IAIA. It is IAIB. Mother is giving B, so it is AB. Here it is IAIO, A group. Here it is IBIA, AB group. Here it is IBIB, B group. Here it is IBIO, B group. Here it is IAIO, A group. Here it is IBIO, B group. If it is IOIO, O group. I hope you guys are very, very clear with this. You check out the question. What is the question? What is the genotype with respect to A blood group phenotype? A blood group can be seen with either IAIA or IAIO. So the answer is D. The answer is D. Clear? Yeah, as you guys have already done a video which is discussed by Sahiti ma'am, which is available in your smart video. So let's not complicate the things. I just want to highlight the most important things associated with the shock, which is a very, very common topic for us in the examination. Okay, if you're ready, we'll start shock, because this is a very important topic. With shock, we'll try to close this session for now, and we'll try to reconnect in the evening. Okay, right? Clear? I want your quick response in the chat box. As of now, 150, 160 people are there, right? Quick, fast. Okay, right. So we have, like, I hope, like, people who are already done smart videos and everything, like exams and question bank and everything, you have so many questions on shock, right? So when I'm talking about shock, there are different types of shock, and most of our questions moves around one type of shock, which is most common. Okay, first question is most common type of shock is. The most common type of shock is hypovolemic shock. The most common type of shock is hypovolemic shock. Okay, because most of your questions will also move around hypovolemic shock only. And this table was discussed by ma'am, and I want to make a very simple miniature version of this table. Let's make it a simple version of this table. So when you're talking about shock, okay, the most common things that we discuss in the shock is cardiac output. We know that the cardiac output, CO, the cardiac output is decreased. You see, in cardiogenic shock, the cardiac output is decreased. Hypovolemic shock, the cardiac output is decreased. Neurogenic shock, the cardiac output is decreased. And anaphylactic shock, the cardiac output is decreased. In all the shocks, the cardiac output is decreased. That is the final outcome of a shock. The basic definition of shock is decreasing in the cardiac output. Okay, right? So, but there is slight difference in when you're talking about septic shock. Okay, so I'll talk about only that part of septic shock. So we know septic shock. Septic shock is basically due to infection, and the most common organisms that are responsible for occurrence of septic shock, 2018 NEET question, gram-negative. Most common organisms or most common bacteria associated with septic shock, the answer is gram-negative, NEET question, repeat. So your septic shock is basically divided into two categories. One is early hypodynamic phase. Second one is late hypodynamic. In early hypodynamic, whenever you have a bacteria, there will be vasodilatation. This vasodilatation will lead to slight increasing in the cardiac output. So in the early hypodynamic phase of septic shock, there will be increasing in the cardiac output. In few textbooks, it is maintained, it is given this line, okay, increased or normal cardiac output, increase or normal cardiac output, okay, right? But in the later phase, in the later stage of the shock, okay, where vasoconstriction is going to happen, your cardiac output is going to decrease. At the end, in septic shock also, the cardiac output is decreased, but in the initial phase, it can be either normal or slightly increased, not heavily increased, slightly increased. I want you to be very, very clear about this concept. Septic shock, one exception is there. Initial or early phase of septic shock, there is slight increasing in the cardiac output, or there may be normal cardiac output. One important point. The next exception I want to talk about is heart rate. You can see heart rates are increasing here, increasing here, increasing here, increasing here. Exception for heart rate is neurogenic shock. This is 2019 NEET question. It was given 2019 NEET question. Very simple. What happens in neurogenic shock? Very simple question. Very, very simple question. The question is also I have kept in this particular class. Okay. So exception of cardiac output is early phase of septic shock. Exception of heart rate is neurogenic shock, right? And you see next one, CVP, same for all. PCW, same for all. Rest everything are not much important for us because they are inclined to many multiple concepts. Most of our questions moves around the cardiac output and heart rate. Okay. Exceptions for cardiac output is septic shock. Exceptions for heart rate is neurogenic shock. I'm done. The next important thing I want you to make a note is shock, that is particularly septic shock. Septic shock has a criteria. The name of the criteria is called as SIRS criteria. Okay, very, very important. I want you to make a note. Temperature should be between 36 degrees to 38 degrees. Heart rate should be more than 90 per minute. Respiratory should be more than 20. Platelet WBC count should be 4,000 to 6,000, 4,000 to 12,000, or 10% of the immature band forms. Sepsis is basically a combination of any of these criteria with the origin of infection. With the origin of infection. This is related to the septic shock, very frequently asked for Neet and Inicet. Very common repeat. This is a very, very common repeat. Which of the following is SIRS criteria? Simple definition they can ask you, related to medicine as well as surgery. And B&L, there is one more important exception I want you to make a note. Normally, in a shock, we know that in a shock, because the shocks are very common, syncope shocks are very common in the case of your general surgery wards or medicine wards when the people are standing for a longer duration of time and everything. So what happens is most of the shocks, hypovolemic shock particularly, you're going to have cold extremities. Peripheries are very, very cold. Okay, you have warm peripheries, two cases. One is septic shock, neurogenic shock. Neurogenic shock and septic shock, you are going to have warm peripheries. You have warm peripheries. Okay, right? And you guys are familiar with hypovolemic shock, where you're going to have hypotension and tachycardia, cold extremities, and most often due to hemorrhage, and it can be treated with a proper replacement of the blood or fluid replacement. The next one is neurogenic shock. I told you neurogenic shock is an exception. It has hypotension, but it is going to have either normal heart rate or brachycardia. In majority of the situations, normal. The question what is given in 2019 NEET examination is what happens in neurogenic shock? The answer is hypotension plus brachycardia is going to happen in neurogenic shock. And this is basically due to unopposed vagal tone resulting from the cervical spine injury above the level of sympathetic outflow. And the last one is something called as spinal shock. Spinal shock means whenever there is an injury to spine, what is going to happen is there will be loss of neurological function or paralysis over a period of time. Sometimes it may extend it over 24 hours, then the recovery can happen. That particular case of loss of neural supply over a particular phase or a particular duration or a particular area which is recovered after a few days comes under category of spinal shock. So now you have few questions in front of you. A 45-year-old male patient is brought to the emergency department after severe car accident, all description, presented with signs of hypovolemic shock. Present with the signs of hypovolemic shock. As the medical team assist this condition, which of the following characteristic is most consistent with hypovolemic shock? Which of the following is more consistent with hypovolemic shock is low filling pressure. Low filling pressure is the most common thing that we find in the hypovolemic shock. That is about 37. Okay, then goes with the 38. A 70-year-old female patient is admitted to the intensive care with a severe septic shock. Here the question is septic shock, severe septic shock. The medical team is assessing her condition to determine the adequate tissue perfusion. Which of the following method is considered as the best indicator for assisting the tissue perfusion in the patient? Okay, again this is a repeat. So it is done basing upon the urinary output. We take urinary output into consideration basing upon that we will be planning the best planning can be done by taking the urinary output into consideration. Right. Shall we proceed or taken off? It is already 12:30. Right. So as of now, I'm closing the session. We'll again meet in the evening at sharp at 6 o'clock. I hope this mode is comfortable. Long back, I used to take so many live YouTube sessions, but I think in the last couple of 1 or 2 years, I was not I'm not so free to come talk on YouTube. Okay, so I hope this is comfortable, right? Same, the comfort is there. Like I think the comfort levels are better than our regular um Zoom classes. I hope you're fine. Okay. I hope the few old students have already 2025 batch or also have attended this session. So I hope you guys are comfortable. Do let me know the responses uh, on the comment session. If you are comfortable to proceed in this manner, we can proceed few more sessions so that the reach of the classes or integrated mode of teaching and everything. Few may like it. Okay. It's not mandatory. We always we are always on a positive side if we get good reviews for the mode of teaching. Okay, right? So, and I hope you like the session. We'll meet again in the evening sharp at 6 o'clock, and do let me know your comments regarding the mode of session and everything, so that if there is anything to be added or anything to be modified, yeah, team will think about that and will try to implement that in further classes. Okay, good day. Take care, and we'll meet sharp at 6 o'clock in the evening. Bye bye. Take care. See you. Bye.